Good morning, good afternoon, good evening to everyone wherever you are joining us from. I would like to extend a warm welcome to you all for joining us for the second City of Hope Global Oncology Symposium on the oncogenic viruses. My name is Javier Ogembo. I'm an associate professor in the Immuno-Oncology department and the inaugural director of the City of Hope Global Oncology Initiative. To set the stage, I would like to briefly offer comments on why we are here today. According to GlobalCan 2020, the global cancer burden is expected to increase by 47% by 2040. That will be almost 29 million cases, with a disproportionate number of increase in low and middle income countries compared to high income countries. Expanding global oncology is a priority to NCI for global health, and the Cancer Moonshot highlights that cancer extends far beyond the borders of the US and recognize that the cancer center burden falls heavily on low and middle income countries. For that reason, in 2021, City of Hope launched the Global Oncology Initiative from our understanding that it will take more than a village to address the increasing global cancer burden and heed the call to expand global oncology both internally and externally. City of Hope has long-standing history of mitigating the cancer burden through collaborative research, training, clinical activities, and capacity building. Our scientists, clinicians, and educators have partnered with institutions in over 100 countries to advance cancer research, training, and education, and millions of people across the world benefit from City of Hope discoveries. We aim to formalize the Global Oncology Initiative at City of Hope by organizing City of Hope researchers, clinicians, and educators, and expanding local and international partnership to tackle the current impeding cancer and global health challenges. And we are well on our way. Since Global Oncology Initiative inception, virtual global oncology forums and annual symposiums have served as the face of the initiative to showcase City of Hope and our partners' global oncology effort to our community and broader audience, and served as a platform to facilitate dialogue between clinicians, scientists, educators, to promote collaboration and advance global oncology. These virtual forums and symposiums have attracted an audience of more than 1,600 participants in 36 different countries. This year, we have gone one step further to organize a symposium with live and virtual speakers and attendees. I am excited to announce that we have registrants and attendees from 18 different countries joining us today. This symposium will focus on oncogenic viruses, which contribute about 10 to 15% of all cancers globally, according to WHO. Today, our expert group of panelists across our 4 sessions will discuss achievements, challenges, and ongoing efforts to mitigate the cancer burden related to viral infection. A note to audience, there will be a Q&A at the end of each session. In-person attendees can ask questions directly using the microphone there. We've only set the microphone on one side because of the camera and also the virtual audience. For virtual audience, please submit questions to ask our panelists through the Zoom chat box, and our team members will ask the speakers also. Please specify the speaker for your questions. Without any further delay, it is my honor to introduce Dr. John Carpten, Ph.D., Chief Scientific Officer, Irell and Manella Cancer Center Director, Distinguished Chair, Morgan and Ellen Chu, Director, Chair of the Beckman Research Institute, Director of the Comprehensive Cancer Center, and Director of the Beckman Institute of City of Hope, to give an opening address. Dr. Carpten is an internationally recognized expert in genome science. He has been a national leader in health disparity research and tireless advocate and a key voice reaching underserved population, ending disparities in cancer outcomes and care, and building a more diverse workforce in cancer research. In 2022, President Joe Biden appointed Dr. Carpten as the first African-American chair of the National Institute of Health's National Advisory Board, a distinguished post that helped set the national cancer research policy agenda with a global impact. Welcome, Dr. Carpten.
It's wonderful, thank you. And all of our visitors, welcome to, I'd love to say, sunny California. Not quite so this morning, a little brisk this morning in Southern California, but I want to welcome everyone here this morning to City of Hope. As you can see, we have our banners here, our mission and our vision. transforming the future of health through healthcare innovation towards the elimination of human diseases such as cancer and diabetes. As Gordon said, City of Hope has a long history, over 100 years, in impacting human health, and particularly with an interest in helping the least of those individuals who may not have access to otherwise quality health care. So we continue to advance in these areas, and we would be remiss to not really understand the impact of the global aspects of these diseases, particularly as we think about cancer. Interestingly, our last two Cancer Center executive meetings have had presentations. In October 9th, it was Gordon who talked about our global oncology program. And yesterday it was Betty Farrell who talked about all of the amazing work she's done in global palliative care. So we have a ton of work in low and middle income countries. I myself also have significant collaborations with a number of research programs and platforms in sub-Saharan West Africa. And we also have investigators who do a lot of work in Mexico and Central America and South America across the Latin diaspora. So this is a very serious area for us, and we're super committed. Lots of discussions with Gordon about advancing this program forward to have even broader and greater impact in this area. We're here in Duarte for our visitors. In Duarte, which is just east of Pasadena. Our catchment area covers most of LA County, San Bernardino County, Orange County, and Riverside County, about 18 million individuals. And we have a very diverse patient population within our catchment that includes almost 40% Hispanic Latino. So we have strong connections again to Mexico. And we also have one of the nation's largest Southeast Asian populations and communities as well that we serve, particularly here on the east side when we think about Pasadena, Temple City, and Monrovia, and out here on the east side. So we're very, very committed and looking to continue to advance and create even new and more impactful partnerships to expand our impact more globally. Really excited about today's agenda. Some amazing speakers, including, I don't want to steal your thunder, dear friend of mine, Dr. Lowy, and I'm really excited about hearing his presentation. So I am going to end my comments here, and I am going to invite Narissa to the stage to introduce Dr. Lowy. Thank you.
And good morning, good afternoon, and good evening. It is my honor and privilege to introduce you all to Dr. Lowy, our keynote speaker. Dr. Lowy is the Principal Deputy Director of the National Cancer Institute, National Institutes of Health, and Chief of the Laboratory of Cellular Oncology in the Center for Cancer Research at NCI. Dr. Lowy received his medical degree from NYU School of Medicine and trained in internal medicine in Stanford University and dermatology at Yale. Dr. Lowy's research includes the biology of papillomaviruses and the regulation of normal and neoplastic growth. The papillomavirus research is carried out in close collaboration with Dr. John Schiller, and they were involved in the initial development, characterization, and clinical testing of the preventive virus-like particle-based HPV vaccines that are now used in the 3 FDA-approved HPV vaccines. Dr. Lowy's growth regulation research is currently focused primarily on the DLC family of tumor suppressor genes and their mechanism of action. In response to the COVID-19 epidemic, he has led the SARS-CoV-2 serology effort at NCI as well. Dr. Lowy is a member of the National Academy of Sciences and of the Institute of Medicine at the NAS. For the HPV research, he and Dr. Schiller have received numerous honors, including the 2007 Federal Employee of the Year Service to America Medal from the Partnership for Public Service, 2011 Albert B. Sabin Gold Medal Award, and the 2012 National Medal of Technology and Innovation, awarded in 2014, and the 2017 Lasker DeBakey Clinical Medical Research Award. So please join me in giving a warm welcome to Dr. Lowy.
Well, good morning, everyone. And Dr. Nossi, thanks so much for this very kind introduction. I was really First, I was very impressed that the City of Hope wanted to do a program like this on global oncology with a focus on viral oncology. This is an important area, but there are many important areas. And one of the things that I want to do at the beginning is to try to explain to you my perspective, why I think this is an important area of study where there also is lots of opportunity. When we are thinking about supporting research, there's always a lot of need, but the question is, where are the opportunities going to come from? So my my disclosures, is it possible to have this on the screen? No, I have it there, but oh, okay, fine. Okay, thank you. Anyway, my disclosures are that I'm an inventor of the HPV vaccine, as Dr. Nonsi mentioned, and so it's been licensed to the two companies that make commercial versions that are FDA approved, and I'm going to talk about briefly about three possible off-label or non-FDA approaches. One, giving fewer vaccines than currently recommended by the FDA. Second, self-sampling for cervical cancer screening, and then in addition, a candidate see and treat approach for cervical cancer screening. I'm also involved in some other technology that's not directly relevant for today. So I'm going to talk at the outset about oncogenic viruses and cancer epidemiology, and then focus on the vaccine, and then a few closing thoughts. And I just want to say that I'm going to talk a little bit about technology at the end. So why should we be studying viruses? I would say that as Dr. Ogembo mentioned, they are an important cause of cancer, but I think that they can be informative for understanding cancer pathogenesis. Intervention against viruses has several advantages. First, targeting the viral determinants is more likely to be scalable and to have widespread impact compared with targeting cell-encoded determinants. I'm not saying we shouldn't do research on targeting cell-encoded determinants. I'm simply saying that because of viruses tend to be responsible for so many different infections and cancers, that targeting them can really be quite useful and often scalable, because you're targeting foreign genes or proteins rather than cell-encoded genes or proteins. Targeting determinants to prevent disease may be easier than treating established disease. I realize we are all familiar with Ben Franklin's admonition when he was talking about fire prevention, actually. An ounce of prevention is worth a pound of cure. And there are really three different areas where I would say this has really come to fruition. First, with the hepatitis B virus vaccine, but second, with HPV vaccine, which I'll talk about, and then hepatitis C virus, the direct acting antivirals, and I believe Dr. Sophia will be talking about them. From my perspective, there are actually substantial advantages for the treatment of chronic infection as opposed to a totally preventive vaccine, because the way that cancer comes about from viruses is that it takes a very long time. And the intervention of vaccination, therefore, you need to wait a long time for it to have its impact on reducing cancer and mortality. Whereas if you intervene where there's prevalent or established infection, you're going to have an impact actually far sooner. Again, I'm not opposed to developing vaccines, but I'm just saying that this actually has an advantage. And preventive vaccination, many people don't realize it, that if you have a long enough duration of protection, you can prevent disease without needing to change behavior. Many of our other interventions, you need to change behavior. I'm going to stop smoking. So you need to stop smoking all the time. I'm going to treat myself for HIV infection. You need to continue treating for a very long time. Vaccination, as long as you take it, it really overcomes that. And most vaccine-induced cancers are more common in low and middle income countries. So this slide depicts for you, when you think about organ systems, the different cancers and the percentage of deaths that are caused worldwide from different kinds of cancers and organ systems. And it's divided between men and women. Not surprisingly, lung cancer is number one. Liver cancer, though, is number two. These are really very important areas of disease. And as shown in this slide, there's actually a lot of viral infections that cause a lot of cancers. So this shows you that HPV, lots, close to 700,000 cancers per year. Hepatitis B, about 350,000. Hepatitis C, about 150,000. Epstein-Barr virus, about 235,000. Human herpes virus type 8, also often referred to as Kaposi sarcoma virus or KSHV. And Dr. Gopal will be talking after me, and he uses KSHV. The official term used by IARC is herpes type 8. And then relatively few with T-cell lymphoma, lymphotropic virus. And Merkel cell is not on the list. We don't have good data about it globally. In the United States, about 3,000 cases per year. So this slide essentially tells you about the distribution. And if you just look at the light colors versus the dark colors, the light colors represent lower incidence, the dark colors represent higher incidence. And when you're looking at HPV, this is, for those of us who are geographically challenged, this is the United States. But you can appreciate that the United States is relatively light, whereas you have large areas of other areas of the world that are dark. Hepatitis B, similar. It's especially a serious problem in Asia. Hepatitis C also outside the U.S., but hepatitis C, in part, largely because of parenteral drug use, is epidemic in the United States, and so that's why this area is dark. So, with that as a preamble, let's talk about cervical cancer and HPV vaccination and screening for a few minutes. This slide shows you what happens in a place like Africa. The blue represents the incidence, the red represents mortality. What I want you to take away is the blue is big, and the red, although it's not quite as big as the blue, is almost as big as the red. If you drop down here to North America, which is really Canada and the United States, you can see how much smaller the blue is. But in addition, the ratio, the red is very small, because fortunately, many women who develop cervical cancer in the United States don't die from their cervical cancer. That's not the case when it comes to Africa. and much of the rest of the world. If the majority of women who get cervical cancer die from it in Africa and many other places. And in Africa and other low and middle income areas, cervical cancer represents about 80% of HPV-associated cancer. So if you look at the United States, incidence is on the left. You can appreciate that even 20 years ago, there was almost twice as high an incidence among Hispanic and Black women as white women, and that has come down, but to a large degree has plateaued, and we need to do better in reducing the incidence of cervical cancer, and it translates to also disparities when it comes to mortality rates, where mortality rates of Black women about 50% higher than that of white women, with Hispanic women in between. So we're going to talk about two different interventions. First, the HPV vaccination, and second, screening. Vaccination is primary prevention. By and large, the vaccine prevents the establishment of infection in most people who are infected. This is not true, for example, of the SARS-CoV-2 vaccine, which many people who have been vaccinated, such as my wife several days ago, have developed COVID. But this is mainly primary prevention, and most vaccines prevent disease, but often don't prevent primary infection. The HPV vaccine does. Secondary prevention is you have established infection and dysplasia, and what's approved is for cervical screening, and that's been very important for reducing incidence and mortality in the United States. So why give the vaccine, and how should it be given? This is just my personal feeling. I don't want people to think this is what the NCI believes or anything like that. I believe that you want to vaccinate women in low and middle income countries for two principal reasons. The first is that cervical cancer accounts and other cancers caused by HPV account more than 90% occur in women in low and middle income countries. In addition, female vaccination is most cost effective. If there were more resources, you would certainly want to do gender neutral vaccination. Where there are more resources in more developed countries, gender neutral vaccination is very useful. But in addition, in the United States, for example, about 40% of HPV-associated cancer occurs in males, very different from low and middle income countries where it's less than 10%. And an important rationale for gender neutral vaccination is it's the fastest way to reduce HPV prevalence in men who have sex with men. If you only vaccinate women, it will take much, much longer to eliminate that reservoir. As Dr. Nunzi said, there are 3 FDA-approved vaccines. They're all based on making virus-like particles. And you'll see that the vaccine actually induces long-term protection. And we think that the secret sauce for that is the repetitive structure of the virus-like particles. And I'm going to, this is the current vaccine that is sold in the United States, Gardasil 9, made by Merck. And HPV 16 and 18 account for most of the cancers, but Gardasil 9, in addition, has the 5 next most common or oncogenic HPV types for cervical cancer. The GSK vaccine and the original Merck vaccine are just targeting 16 and 18, and the Merck vaccine also 6 and 11, which accounts for about 90% of genital warts. So this slide from the CDC gives you the different cancers in women and in men that are widely attributed or agreed to be attributable to HPV infection. And notice that oropharynx, actually there are more cases of oropharynx cancer in the United States than there are of cervical cancer in the United States. And this is because their incidence has gone up substantially, whereas cervical cancer screening and follow-up has really had a major impact. If anybody wants my slides, just ask for them, and I'm happy to send them. And the dark blue is 16 and 18. The lighter blue is the additional 5 types in Gardasil 9, and the white are the ones which are not directly protected by the vaccines. So here are 4 salient features about the vaccine: high efficacy and long duration of protection. The vaccine confers sterilizing immunity in most patients. It prevents infection. The vaccine induces herd immunity even with suboptimal uptake. There's substantial herd immunity documented, particularly among women. That means that women who have not been vaccinated have less likelihood of acquiring the HPV types targeted by the vaccines because of herd immunity has decreased the prevalence of those types. Importantly, the vaccine does not treat established infection. Of course, that would be desirable. What about cervical cancer? This shows data from one of several different countries that have shown that women who are vaccinated when they are younger than the typical age in that setting for initiating sexual activity, there's close to a 90% decrease in cervical cancer incidence in the women up until they're about 30. That's as far as the data have gone. And that's shown here on the left. If you look on the right, the women vaccinated when they were 20 to 30 years of age, with regard to cervical cancer prevention, there's no difference for those women during this observation follow-up period. As the women get older, the curves will diverge, so they'll look more like this one for the women vaccinated at 17 to 19. But really vaccinating, at least this is from Denmark, vaccinating when they're 16 or younger, that's when you will really have the greatest benefit. I have one slide about the United States for vaccination because I think it's so important. Provider recommendation increases the uptake of HPV vaccine about 20 percentage points compared to no provider recommendation. And these data from the CDC, what's really impressive is it's not a one-time deal. You see it year after year after year that this is going on. So the problem we have is, what about worldwide vaccine uptake? What you've seen is that the cancer burden for HPV infection is largely born in low and middle income countries, 90% of the cancers, 90% of the mortality. Currently, only about 10% of adolescent girls are vaccinated there. So we need to compile more evidence, because our hypothesis for the last few years has been that one dose of the vaccine can induce long-term protection. But our observational data, if you will, or post hoc data, have been sufficient, along with other data for the World Health Organization last year, to recommend 1 or 2 doses for 9 to 20-year-old women. These are our data from our original Costa Rica vaccine trial, where we started testing the GlaxoSmithKline vaccine called Cervarix before it was FDA approved. And what I want you to see is that 100% of the one-dose recipients remain seropositive, and their efficacy against infection is no different from the efficacy against 3 and 2 doses. So what I hope you can appreciate here is that after a couple of years, you really get this plateau for antibody levels. And these results are unprecedented for a subunit vaccine. But similar results have been seen in the International Agency for Research on Cancer sponsored trial with Gardasil, with the Merck vaccine. So this is something inherent to the vaccine. We think that the key really is that the vaccine, the multimeric form of the vaccine, because there are 72 pentamers for the virus-like particles, and they bind to the B-cell receptor, the virus-like particles, and they induce strong survival, proliferation signals, high levels of antibodies of long duration. You know, think about this in comparison to tetanus, okay, where you need to be vaccinated repeatedly. And as wonderful as the SARS-CoV-2 vaccines have been, their protection from a couple of doses lasts months, not years. So what about conducting research in low and middle income countries? We do all of our HPV vaccine efficacy trials in Costa Rica, not to exploit Costa Rica. That's when we started down in Costa Rica 30 years ago, it was their #1 cancer of women. And we've been there for the duration, but it's very important to guard against exploitation of the affected population. Studying an intervention that's too expensive for the country. You don't want to do that. Consider doing research in low and middle income countries. And if it's successful, it should be an intervention that can be applied in low and middle income countries. Conducting research on a common problem should be able, in principle, to help that, if it's positive, help that country, other low and middle income countries, and even high income countries. So there are a number of one-dose trials now going on, including 2 of the NCI trials. 18 months duration of protection was shown for the Kenshi trial in Kenya, and there's 95% efficacy from a single dose. And as I mentioned, the World Health Organization now is recommending 1 or 2 doses. We would like a global recommendation for just 1 dose. We think that that would be the most equitable way of doing things. So just 2 slides initially about cervical cancer screening. This is very worrisome. In 2005, only 14% of women were underscreened, or overdue for their screening. By 2019, the year before the pandemic, this has 0 to do with the pandemic, it went up to 23%. And you can see that the women who were uninsured, public insurance, you know, they were particularly the ones who were underscreened. And we really need to change that. At NCI, we're working with the FDA and pharmaceutical companies, diagnostic companies, to try to get self-sampling approved, because we think this could be an intervention that could be useful for underscreened women. It's already approved in quite a few countries and recommended by the World Health Organization, but for various reasons, not yet by the FDA. The last topic is really 2 slides about technology and health disparity. My own view is that technology can decrease disparities, increase disparities, or be neutral. And my feeling is that you don't want to wait until the end to consider the possible impact on disparities. We have so many examples where we wait until we get FDA approval, and then we say, oh, what's going to happen for disparities? I think we'd be better off to increase the likelihood of development, decreasing disparities, to think about disparities from the beginning. And even more direct, develop technology whose goal includes reducing disparities. We can't do that all the time. And if you have a great idea and it's, it's not directed towards disparities, that's important. But think about that possibility. So before I wrap up, this is my colleague Mark Schiffman is developing a system, which is a two-stage system for high quality cervical cancer screening, where that we think will be cost effective enough for low and middle income countries. And it's currently being tested in about 100,000 women in Africa, Latin America, and Asia. Basically, first, an inexpensive on-site HPV DNA test, and then the positive women get automated visual evaluation and artificial intelligence algorithm that's embedded in a smartphone that basically tells the operator when they take a photograph of the cervix, this is something does not need to be treated, something that can be treated with thermal ablation, or it's a very extensive area and should be referred to a specialist. So here are a few take-home messages for you to consider. Studying cancers caused by viruses is an important opportunity to contribute to progress against cancer. When designing research or interventions, think about potential benefits to people beyond our borders, especially low-resource settings. When developing new technology, consider implications for health disparities from the beginning. And HPV vaccination and cervical cancer screening are two effective interventions from which all people from all countries should be able to benefit. Thanks very much. And I guess we'll have a Q&A at the end.
Thank you very much, Dr. Lowy, for that illuminating presentation. Now I will introduce you to the next speaker. Our next speaker is Dr. Satish Gopal. He will be doing this presentation virtually from the NCI. To introduce Dr. Satish Gopal, M.D. Ph.D., M.D. M.P.H, was appointed Director of the Center for Global Health at the National Cancer Institute in 2020. In his role, he oversees the development of initiatives and collaborations with other NCI and NIH partners, NCI-designated cancer centers, and other governmental and non-governmental organizations to support cancer research, promote science-based cancer control, and build research capacity in low and middle-income countries. Dr. Gopal earned his medical degree from Duke University of Medicine in 2001. He completed internal medicine and pediatric training at the University of Michigan and pursued medical oncology and infectious diseases training at the University of North Carolina. As an extramural physician scientist, his NIH-funded research program focused on epidemiologic, clinical, and translational studies of lymphoma and HIV-associated malignancies in Africa. And he oversees a multidisciplinary cancer research portfolio that sought to address many of the commonest cancers in the region, including cervical, breast, esophageal cancers. He has authored over 100 publications in top journals in the field and serves as the U.S. representative of the Scientific Council for the International Agency for Research and Cancer on Cancer, IAC. Welcome, Dr. Gopal.
Thank you so much, Dr. Ogembo. I'm really delighted to participate in this important symposium. I'm sorry to not be able to be there in person, but look forward to visiting City of Hope in person, hopefully sometime soon, and grateful for the opportunity to participate virtually. I hope my talk will be a nice complement to Doug's presentation. I'm going to talk a little bit about EBV and KSHV specifically in Africa. I commonly use this slide because I work quite a lot on Burkitt lymphoma, simply to illustrate the ways in which I believe we've learned a lot about oncogenic viruses in Africa and indeed cancer research, but have done much less well at alleviating the human suffering that they cause. And as you all will know, Dennis Burkitt was an Irish surgeon who described this new human tumor in the 1950s when children in Uganda presented to him with this aggressive craniofacial tumor. and which we now know as Burkitt lymphoma. And I think this audience will be very familiar with the decades of really seminal discoveries in cancer research that followed from this, that now result in patients with Burkitt lymphoma, at least those who are able to enroll in a clinical trial in high-income countries, really having amazingly good outcomes. And the point I often make is that I think it's a failure that we have failed to use this accumulated body of knowledge over many decades to really develop a solution that is applicable back to the very children in Africa who helped initiate these decades of discovery. And I truly say this not to be incendiary, but simply based on observation during a decade living and working in Africa, during which time I routinely saw patients who presented just as they did for Dennis Burkitt in the 1950s who experienced approximately the same outcomes as they might have in the 1960s and 1970s. Doug already alluded to these data, and I'm just going to elaborate for just a moment. So again, these are IARC analyses of the burden of infection-associated cancers worldwide. And the point I want to make here, in addition to what Doug already alluded to, is that there's marked geographic variation around the world, and EBV and KSHV remain important causes of cancer, particularly in Africa. So, for example, H. pylori has a very significant burden, particularly in East Asia. As Doug already mentioned, HPV burden is particularly notable among women due to the cervical cancer epidemic in sub-Saharan Africa. Hepatitis B virus principally in East and Southeast Asia. Hepatitis C virus-associated cancers principally in Western Asia and Northern Africa. And what you will see here is, apart from the cervical cancer burden among women in Africa, sub-Saharan Africa, relative to other world regions, doesn't seem to have a huge burden of cancers associated with these other infectious agents. The point I was making here is that EBV and KSHV are particularly important, relatively speaking, to other infectious agents that cause cancer in Africa. And in particular, KSHV, this is the only part of the world where KSHV has this level of population level importance in terms of cancer burden. The other thing I want to point out here is that in these analyses, our IARC colleagues relied on cancer registries, which are notoriously limited in terms of under-ascertainment, under-diagnosis, and also population attributable fraction for cancer, particularly in low and middle income countries, and particularly in Africa. And they also considered only Burkitt, Hodgkin, and nasopharyngeal carcinoma for EBV and KS for KSHV. And I'll talk a little bit about why I believe the breadth and diversity of EBV and KSHV associated cancers in Africa is quite a bit broader than that. So this is Malawi, where I lived before being recruited to the NCI by Dr. Lowy. Malawi is a beautiful country in southeastern Africa. And I've just illustrated here some of the economic development and health system characteristics of Malawi during the period of time that I lived there. These numbers have changed slightly since then, but I wanted to provide really a context for some of the work that I'll describe on the subsequent slides. So first thing we tried to do in Malawi during the period of time that I was living there is really build a clinical research infrastructure. And what this allowed us to do was appreciate that the spectrum of EBV and KSHV associated suffering is quite a bit broader and more diverse than had been appreciated. And this infrastructure included, upgrades to treatment capacity, improved data registration systems at our hospital, but very importantly, a major investment in diagnostic services, including pathology. And this is our lab shown here, where sample prep is occurring. And this is a weekly telepathology conference that we ran between Malawi and the United States, with clinicians and pathologists on both sides, reviewing cases, coming to a consensus diagnosis, and really learning from each other. I have an adjunct appointment now in the lymphoid malignancies branch at the NCI Center for Cancer Research, and I actually participate in a very similar conference each week that's run by Lou Stout, Wyndham Wilson, and Elaine Jaffe. And every week I'm struck by how similar the conference was that we were running in Malawi to the one that now is ongoing at the NCI. What this allowed us to do was to achieve comparable diagnostic accuracy to the US with much lower resource utilization. And so this is just a figure from a paper where we describe the number of additional stains that were applied on secondary review in the United States to essentially arrive at the same diagnosis that we had reached in Malawi. And it also allowed us to provide some of the first detailed characterization of several unique disease entities, including entities associated with KSHV and EBV. I told you already in the IARC analysis that for EBV, only Burkitt, Hodgkin, and nasopharyngeal carcinoma were considered. And for KSHV, only KS was considered. But we described really for the first time in detail to our knowledge in an African context, multicentric Castleman disease and primary effusion lymphoma, which had previously not been well described in an African context, despite broad appreciation of the large KS burden in Africa, as well as extranodal NKT cell lymphoma and plasmablastic lymphoma associated with Epstein-Barr virus. This is just a table from actually a grant application a few years ago where, and we're in the process of updating these data, where we just took consecutively evaluated pathologically confirmed lymphoma specimens in Malawi and stratified them based on EBV status as assessed using EBER in situ hybridization. And what you will see is slightly less than half of tumors were EBV positive and the rest were EBV negative. And there's a big difference between these two patient populations. So the EBV positive lymphomas are quite a bit younger, a median age of 15 as opposed to 45 in the EBV negative lymphomas. I showed you a couple of slides ago that the HIV prevalence during this period in Malawi was 9%. So it's higher among patients with EBV positive lymphoma, 23%, but higher still among patients with EBV negative lymphoma, that is 47%. And this surprised us, frankly. Mostly what we saw in the HIV positive population was EBV negative lymphomas. And we actually saw more EBV positive lymphomas in an HIV negative population. And again, those were surprises to us. And we tested this not only by EBER in situ hybridization but also by multiple other methods. And the histologic spectrum of these EBV positive and negative lymphomas is also quite different. So with EBV positive lymphomas, we saw, as expected, quite a lot of Hodgkin and Burkitt, a small number of diffuse large B-cell lymphomas, which typically occurred in HIV negative individuals, plasmablastic lymphomas, which we saw both in HIV positive and negative individuals, and then extranodal NKT cell lymphoma, again at an appreciable frequency only in HIV negative individuals. And the EBV negative lymphomas were largely diffuse large B-cell lymphoma, many of whom were HIV infected, but most of which were EBV negative. A small number of Hodgkin and Burkitt lymphomas in the EBV negative group, and then again, a small smattering of other less common lymphoma subtypes. What the recognition of some of these specific virus-associated histologies allowed us to do was then to tailor therapy and in particular intensify chemotherapy. So some of these virus-associated lymphoma subtypes like Burkitt lymphoma, like plasmablastic lymphoma, like primary effusion lymphoma are known to not respond well to kind of moderate intensity chemotherapy like CHOP, which is really the international standard for most non-Hodgkin lymphomas. And that's illustrated here for adolescents and adults with Burkitt lymphoma specifically. So a recurring theme in all our work is that outcomes were not primarily driven by HIV status, and this is comparable to contemporary trials for lymphoma in patients with HIV and without HIV with lymphoma in high-income countries. Outcomes were really driven by prognostic factors associated with the lymphoma itself, that is stage, LDH, performance status, etc. And we found that, again, recognizing some of these virus-specific entities and progressively and iteratively and adaptively intensifying therapy really did lead to meaningfully better outcomes. In this instance, for adolescents and young adults with Burkitt lymphoma, we actually applied the infusional EPOCH regimen developed by my colleagues Lou Stout and Wyndham Wilson at the NCI. We are not able to apply EPOCH in Malawi in the same way that we do at the NCI. We can't achieve the same dose intensity. We can't achieve the same cumulative dose, but we were able to adapt and tailor a version of the regimen that made sense for us that really did result in better outcomes. And we were pleased to continue treating patients in this manner. There is, I think, also, however, a cytotoxic ceiling beyond which therapy can't be escalated in a Malawian context. And I I showed you already that that's because the health system spends $35 per person per year on all health-related needs, and you're reliant on the health system as a whole. So even if you can exert a high degree of control within your clinic, when a patient is home and develops a fever and goes to their peripheral health center, a point of vulnerability is what happens at that health center, right? So there is, I think, a real, we can't administer the same intensity of chemotherapy in a Malawian context that we can at the NCI. And so we, in addition to intensifying therapy, we also thought a lot about how we might find other ways to improve outcomes. One of the ways that we sought to do that was to try to better risk stratify and assess response so we could better tailor therapy to individual patients. And we actually, back in 2015, 2016, 2017, sought to apply liquid biopsy principles. We were aware of a lot of the emerging data around nasopharyngeal carcinoma from Asia, demonstrating that plasma EBV worked quite well for population level screening, but also for prognostication and response assessment once patients were diagnosed with nasopharyngeal carcinoma. And we thought this is likely applicable for EBV positive lymphomas in an African context, although this hasn't been, to our knowledge, clearly demonstrated. The other advantage here is this allowed us to repurpose existing infrastructure. HIV RNA instruments were widely distributed throughout Africa in support of HIV treatment programs, and we essentially used those same instruments and repurposed them with other commercially available kits and different primer sets, such that HIV treatment monitoring equipment now became cancer treatment monitoring equipment. And this is just data from a cohort of children with Burkitt lymphoma in Malawi, demonstrating that plasma EBV, like many of the sophisticated MSET assays that are now being investigated or proceeding to commercialization, levels are very high at baseline, a median of 10 to the 6 copies per ml, decline over the course of treatment, and typically increase at the time of relapse. These are trajectories for individual children. This has marked prognostic importance at baseline, but also at the midpoint of treatment. That is, children who survive to the midpoint of treatment, if they have persistently detectable plasma EBV, that seems to be associated with a worse outcome. And you can imagine now that this could be used like we use a PET-CT for lymphoma risk stratification and response assessment in a high-income country. And a quantifiable blood-based biomarker is particularly valuable in a setting where we're otherwise using relatively crude methods to risk stratify and assess response. We were typically doing this with our hands, a flexible tape measure, a chest X-ray, and an abdominal ultrasound. Occasionally a CT, but and PET-CT, we didn't have PET-CT, so PET-CT is limited in a number of ways. The main limitation is that it's not widely available in an African context. So I think these kinds of strategies have tremendous power. And this is just showing that even adjusted for many other factors associated with increased mortality among children with Burkitt lymphoma, in an adjusted model that included all of these, it was really plasma EBV that retained independent predictive value, with each log increase being associated with a 35% increase in mortality. I haven't shown these data, but this works identically well for children for EBV positive Hodgkin lymphoma as well. We've reported on that. So there's a limit to how much we can maximize cytotoxic intensity. Liquid biopsy principles might also be applicable in some contexts. We also sought then to apply newer non-chemotherapy targeted treatments. And I've put novel here in quotations because this, to our knowledge, is one of the first evaluations of the anti-CD20 monoclonal antibody rituximab in a clinical trial in Africa, which we reported on a couple of years ago. We did this initially in diffuse large B-cell lymphoma, which I showed you is the most common lymphoma subtype that we saw. This is primarily in HIV positive individuals and is typically EBV negative, as I already told you. But these were patients with very advanced disease, bulky disease, and a median LDH 2 times the upper limit of normal, which is much higher than a typical cohort in the US. And we found that rituximab could be safely and effectively applied to this population with a 2-year progression-free survival of 59% and a 2-year overall survival of 55%, which is really in this population a proxy for cure. And we're really using these data now to apply rituximab to other virus-specific histologies, in particular Burkitt lymphoma and also multicentric Castleman disease, which I'll speak about in just a moment. These data are among the best that we are aware of for a comparable patient population in an African context. They are not the same as one might expect in the United States, but they are starting to approach what you might expect for a comparable patient population, even in contemporary clinical trials in a high-income country. And so continuing these efforts is really important to us and is work that's ongoing. Apart from safety and efficacy, we also thought a lot about how to make a broader argument to policymakers, development funders, about the value of these kinds of public health investments. Cancer treatment will always seem like an expensive intervention in an African context, especially relative to HPV vaccination, clean water interventions. But the reality is when you're applying these in a time-limited way, particularly for a curative indication to relatively young patients with maybe no comorbidities who might be cured over from a health system perspective and over a lifetime horizon, these can be actually very prudent public health investments. And so we tried to generate the data that would demonstrate that by drawing on detailed clinical data from our cohorts and trials, but also carefully collected microcosting data that we embedded in all of these activities. And really what that allowed us to show is that these are very actually cost-effective interventions, even relative to many other things that have been widely accepted as suitable public health investments in low and middle income countries. And this is just showing a probabilistic sensitivity analysis for CHOP, showing that even when you vary the model inputs across a whole range, in overwhelmingly, CHOP is an extremely cost-effective intervention, meaning that it comes in at a DALI averted at less than 1 times the GDP per capita in Malawi. And even our CHOP is cost-effective in about half of these simulations, coming in at a cost per DALI averted at less than 3 times GDP per capita. This is a heavily contextualized analysis where dependent on the GDP of a country in which the analysis is being done. And I just want to take a second to maybe offer a more universalist view, which is that our CHOP, so rituximab, we use the biosimilar rituximab from India, which costs about $3,500 for a treatment course in Malawi. And that's, I told you already that the annual health expenditure per person per capita in Malawi is $35 US. So you're asking essentially the government to spend what it would spend on 100 people for all health-related needs in a year on one person who may require rituximab. And again, that's not intuitive that would make public health sense, but it does from a health system perspective and over a lifetime horizon. And the reality is that RCHOP really becomes the dominant and preferred strategy once you have a willingness to pay threshold that's above about $1,000 per DALI averted. And I just want to editorialize here briefly that in the US, our willingness to pay threshold is usually on the order of $50,000 to $150,000 per QALY averted. So let's just take $100,000 per QALY averted as a median. I think what this means to me is that as a cancer research and control community, we are valuing the life of a patient with cancer in Malawi at least 100-fold less than the life of a patient with cancer in the United States. And again, I truly don't say that to be incendiary. This is just my empiric conclusion based on the data that we've generated in Malawi. So I want to talk just for a second about multicentric Castleman disease. The other thing our infrastructure allowed us to do was really identify and address new emerging virus-associated comorbidities. And thus, I've illustrated this with multicentric Castleman disease. This had really not been well described in Africa, despite a large KS burden. It's a polyclonal lymphoproliferative disorder that's technically non-malignant, but can be rapidly fatal, characterized by severe systemic inflammation. This is a characteristic pathologic image taken from our lab in Malawi with an involuted germinal center and then KSHV-infected LANA-positive lymphocytes and plasmablasts in this perifollicular mantle zone. And for contrast, this is in C panel C and D or KS in a lymph node, where it's the spindle endothelial cells that are KSHV positive and LANA positive by staining. For us, multicentric Castleman disease was 14% of all pathologically confirmed lymphoproliferative disorders among people living with HIV in the long way between 2013 and 2020, despite not having been well described in Africa overall. And so we think there's really a substantial under recognition problem. There is some incident in data from high income countries suggesting that incidence of MCD may increase as ART becomes more available. And that's consistent with the general phenotype of patients that we saw in Malawi. That is, these were typically patients who had been on antiretroviral therapy for many years, often with very good CD4 counts and viral suppression. This is a very different phenotypically HIV-infected population than, for example, our HIV-infected patients with diffuse large B-cell lymphoma. And we're continuing a lot of work around MCD because we think it may be very important for the future. We think incidence may actually increase as ART scale-up continues. We think there's a substantial under-recognition and under-diagnosis problem, especially at the community level, and are thinking about how to address that. We think this may contribute in part to unexplained early deaths after ART initiation. We have described MCD in Malawi as a immune reconstitution phenomenon after patients have initiated antiretroviral therapy. And ART initiation in Africa has been plagued by a persistent early mortality problem that has been quite difficult to address and unpack because the causes are uncertain. So I don't think MCD is responsible for all of it, but I think it may be responsible for a fraction. MCD is often rapidly fatal without rituximab, which typically results in long progression-free and overall survival after short course treatment, weekly treatment for 4 weeks. And now, building on our diffuse large B-cell lymphoma experience, we're now applying rituximab to MCD patients. And I think this also may bear consideration as immune checkpoint inhibitors are introduced to treat cancer in populations with high KSHV prevalence. Many of you will know that immune checkpoint inhibitors work for KS, but there is an MCD-like phenomenon that has been rarely described in KS patients treated with immune checkpoint inhibitors, typically KS patients who are KSHV viremic. This is not very common among KS patients in the US, but is actually pretty common among patients in African contexts, and I think this might bear watching. All of the work that I've talked about already is really about first-line diagnosis and treatment for patients with virus-associated lymphoma subtypes. There's virtually nothing to offer patients in the second line in Malawi, despite in the US having CAR-T and many other things that could be offered in second, third, and fourth line with significant curative potential. We've been very interested in the possibility of immunotherapy, I think drawing on many studies that have shown real promise for specific EBV-associated lymphoid malignancies. And indeed, there are 2 active clinical trials ongoing at the NIH Clinical Center that are enrolling patients with and without HIV with virus-associated malignancies and testing these kinds of strategies, the application of immunotherapy to such populations that are actively enrolling now. As such, we have a real interest in expanding some of this work to Africa and are planning for a study that hopefully will start next year in partnership with Roche that would essentially be a companion protocol to studies that are already enrolling at the NIH Clinical Center. And the general outlines of this are shown here. But again, I think a really important opportunity to start paving the way to access for these critical cancer medicines in Africa and study how they will work and for what patients they may be particularly beneficial. And going back to the original slide, I think this is all the premise for all of this work is really, could an evidence-informed shift from a pathology and imaging-guided cytotoxic treatment paradigm to a more molecularly guided non-cytotoxic treatment paradigm overcome some of the deployment challenges that we have had with current approaches while building local capacity for cancer treatment and trials. And then this is just my capacity slide, which is just that all of this work really allowed us to bring together a remarkably diverse community, particularly of young investigators who are developing careers, working on various aspects of the portfolio that I described, and I think are really committed to EBV and KSHV suffering worldwide. So I'll end there. I'm very sorry for the technical glitch and just another reason to try to come in person next time, but look forward to the discussion.
I will go ahead and start our Q&A session. And we have a microphone audience. We're also fielding questions online. Up and state your question. I'll get us started off. Dr. Lowy, fantastic presentation. First of all, thank you so much for sharing your insights. I was wondering what you see as the biggest obstacles to progress in global oncology.
Money. Lack of funding is really, I think, the biggest problem. There are so many interventions that we have developed that have been widely deployed in the United States, but it's very hard in lower resource settings to deploy them. And so on some level, we end up needing to develop other approaches that can work. I mean, I think, Satish talking about, trying to really use state-of-the-art current inhibitors for some diseases, and doing that in Africa is really terrific. But you need tiered pricing that is, assuming that the results are positive, that will permit widespread deployment of the intervention. Otherwise, it's almost, a tease to do a study like that. But, I've discussed this with Satish, and the company is committed to deep tiered pricing.
Is
It was a wonderful talk and a very relevant topic. The subtypes of HPV, of course, there are many of them, and some of them are more connected to oncogenesis than others. The vaccine that you developed with your colleague does cover a number of subtypes, but there have been improvements over the years. I guess one question is, what is your opinion about the improvements in terms of the breadth of recognition as well as patient outcomes?
Well, I mean, it's a very important question. Should there be a third generation HPV vaccine is really the question. And what if there were, what should we think about its characteristics? And I guess I see really two different, not opposing improvements. One could be, if you will, a pan-HPV vaccine against the HPV types that cause cancer. And in principle, that is possible. Technology is there. But another possibility could be to, in addition, protect against non-genital warts, which are a major problem. It's not cancer, but in the United States, certainly we expend a lot of money for warts. And so those, I think, would be the two main targets, if you will, that for the unmet need, with prioritizing the cancer part, perhaps higher. What right now you're targeting, let's say 90% of the cancers, but it's not, you can forget about it. But an additional point that I think many people don't take into consideration is, if you had a pan-HPV vaccine, you could probably eliminate cancer screening for HPV-associated cancer, let's say after 30 years, or, after people had taken those vaccines.
Thank you.
Hi, question for Dr. Gopal. I was really interested in your talk about the increased incidence of the sort of inflammatory sequelae associated with immune reconstitution, Castleman's disease associated with immune reconstitution in Africa versus in the United States. What do you think? Do you have any theories as to why that might be the case?
Well, I think the pattern is similar. So again, I think unlike most HIV-associated comorbidities, the one problem is that MCD is incredibly rare in the United States. So, it takes decades to accumulate a cohort of the size that we were able to accumulate in Malawi in just a few years. So it's hard to kind of study the epidemiology of MCD, but there is some data suggesting that, unlike most other HIV-associated comorbidities, which decline in incidence as ART is scaled up, MCD may actually increase. So there is data suggesting that from high-income countries. And I would say, and people, actually my colleagues at the NCI, Eric Engels and Sam Mbulaitier, had looked in Africa for MCD back in the 90s before ART was widely available at Makerere University in Uganda by going through the pathology archives and essentially had not really found any MCD. And I think that's because it was before ART was really available. We really have seen kind of an epidemic in Malawi. And I think as we began to understand that this was occurring, of course, then we sensitized the community, patients started to get referred to us. And I think that experience is accumulating now in other African centers as well. So again, we saw it at much higher frequency, for example, than Hodgkin lymphoma, which is a very different pattern than you would expect for lymphoproliferative disorders in an HIV-infected population in the United States. So we do think this is an important emerging comorbidity, particularly as ART is scaled up. And I think and the other problem is it often presents in a fairly non-specific ways because it's characterized by this severe systemic inflammation. So it's diffuse lymphadenopathy that's usually relatively small. It's fever, it's systemic symptoms, it's anemia. So our expectation is that at a community level in HIV clinics, these patients are often getting treated with antibiotics, with TB medicines, without a biopsy being done that would really demonstrate MCD, which requires a very different sort of treatment, rituximab. So we're actually thinking a lot about how to better use our experience at the tertiary care center to develop a platform that would allow this to be better recognized at a community level in HIV clinics.
Thanks.
Yeah, thanks. Outstanding. Doug, you've heard me talk about it before. We don't have to go to Africa when we think about HPV problems. You just go to the Mississippi Delta, right? I mean, I grew up there. And there's certain areas in the Mississippi Delta that aren't that different, right, from many low and middle income countries. So I guess the question is, what do you see the differences, right, in terms of the problem in the Mississippi Delta versus, for instance, a problem in low and middle income countries such as in Sub-Saharan West Africa? And are there things that we can learn from either experience that could help deal with the issues in either of those areas, or the problems just very different?
In principle, John, it should be easier to provide access in Mississippi than in Nairobi. But I think that you identify similar problems, but I think they are largely problems of access. And part of what I think has happened in the United States is that because of advances in cancer research, changing standard of care, we now see disparities between urban and rural populations that weren't true in 2000. And therefore, we need to make changes in the United States, not just in Mississippi, but I think that thinking about bringing cancer care and control to the patient instead of the patient to cancer care and control is, where feasible, something that might be able to alleviate, if not totally, eliminate those disparities.
On that topic of access, you talked about single-dose HPV vaccination, very hot topic, one that many people are excited about. Can you expand a little bit more about why you think it should be a worldwide recommendation and not really just focus on low and middle countries?
To me, the notion of a worldwide one-dose recommendation is really an issue of equity. What my colleagues and I worry about is that you end up with a World Health Organization recommendation for one dose, but not in high-income countries. And so you end up in this situation where if you can afford it, you really want to have two doses, but one dose is good enough for you. And so that's what I think could be the big difference for a global versus what we are trying to prevent happening, which is a two-tiered system.
So this is a connected question. So the first part of it has to do with the fact that in parts of our country, there are people who believe that taking Gardasil or Cervarix will increase promiscuity. Hence, in the United States, while the access is pretty universal, the misinformation, disinformation equally as great. Maybe you can discuss that. And then on top of that, since the frequency or the number of people who are now receiving these vaccines somewhat lower than what we would want, maybe you can also discuss whether there is any progress in a therapeutic vaccine and you already have been diagnosed with cervical cancer.
Yeah.
Thank you.
So let me take the last question first. All of these are important issues. Therapeutic vaccination would, of course, be highly desirable, but it is much easier to talk about it and think about it than to make one that is really highly efficacious. I mean, there are data that you can have that there are candidate vaccines that work better than placebo or better than the adjuvant, but they're just not good enough yet to be FDA approved. In terms of the uptake of the vaccine, I have been amazed that during COVID, HPV vaccination went up, not down among teenagers. And now 75% of teenagers, boys and girls between 13 and 17, have been vaccinated. Would it be better if it were higher? Of course. But although there has, when the vaccine was newer, it was approved in 2006, which is now a long time ago. There were these concerns, but there have been a lot of observational studies indicating that the concern about increased sexual activity does not seem to be valid. And it's not just one study, it's many. And I don't think that this is, there may be some parents who still are concerned about it, but I don't think that it's having a big population-wide impact.
So much for your excellent presentation. Just going back to the point that you just made about the potential for a two-tier system with regards to the global recommendation for the one dose versus having a different recommendation. Can you speak to the potential for a two-tier system for cervical screening and it's very exciting to see that the NCI is now sponsoring the last mile trial for self-sampling. So how do we potentially eliminate the risk of a two-tier system for cervical cancer screening? And is that at all possible?
Yeah, I mean, the question is, cervical cancer screening has been demonstrated in the last 60 years to be very effective in reducing the risk of getting cervical cancer and reducing mortality because you diagnose earlier stage disease, usually pre-cancer rather than even early stage invasive cancer. The reason, again, comes back to, I would say, my answer to the first question, which is resources. It's really, it costs a lot of money to set up a sustained program of cervical cancer screening in low resource settings. Many countries simply don't themselves have those resources. My hope would be that there would be subsidies very analogous to what the Gavi Alliance does for vaccines, because it would be highly beneficial. But I think that we could try to reduce the gaps. I think it'd be very hard to eliminate them. Just see what happens in the U.S., as Dr. Carpten was alluding.